On Health Matters Television for Life, from active to on the bench in an instant.
Couldn't walk on it, I couldn't put any weight on it.
For a Spokane man coaching soccer, all it took was one misstep.
Planted my right foot, twisted, and blew out my knee.
How surgery and physical therapy got him back on his feet. From fixing an ailing joint to healing a broken bone, hear from a panel of experts and find out what your options are. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSBS, and by Providence Healthcare.
As the saying goes, children aren't just short adults. They have special needs. I'm Dr. Judy Felgenhauer. I chose Providence because they see the need for specialized care just for children.
Find your doctor online at phc.org.
Providence has the best professional and the best nursing staff, without which we could not do these complex procedures. I'm Dr. Stephen Nisko, and I choose Providence because Providence is fully invested in my success and in the success of my patients.
Good evening, I'm Teresa Lukens. Our topic tonight is joints and bones. Now, doctors can do some amazing things in the operating room to get tired and injured bodies up and running again. And it's not just athletes that we're talking about. Our panel is here to talk surgical options and the role of physical therapy. So let's meet them. Dr. Jonathan Keeve is with Northwest Orthopedic Specialists. His specialties include joint replacement, sports medicine, trauma, and fracture care, as well as hips, knees, and shoulders. Dr. Jonathan Linthicum is with Kootenai Health. His specialty is joint replacement. Jonathan Hook is a board-certified clinical specialist in orthopedic physical therapy. He works for Physical Therapy Associates in Spokane. His specialties include acute and chronic orthopedic conditions and sports medicine. Dr. Erica Burns is with Providence Orthopedic Specialties. She is an orthopedic surgeon who specializes in treating shoulders. And finally, Dr. John Schuster is with Northwest Orthopedic Specialists. His specialties are the back, neck, and spine. And I want to thank all of you for being here tonight. It is no joke that I have 4 Johns in the house tonight and an Erica, and I want to thank all of you for being here. I also encourage your phone calls this evening as well as your emails. You can ask our doctors anything about joints and bones or replacements. And I want to start by talking about what you commonly see this time of year, because as I understand it, these sorts of injuries to the joints and bones can be quite seasonal.
Well, it's a slippery time of year outside, and some people don't have the greatest balance or the best shoe wear, and down they go. And depending upon what hits the ground first, they can break their hip, their wrist, their shoulder. So it doesn't discriminate against body parts or people. All ages can get fractures from falling in the ice. So that's probably the most common thing.
Mm-hmm. We're also talking about skiing injuries, sledding injuries. We have a lot of snow this year in the mountains.
Yes, I've seen several clavicle fractures, a lot of broken wrists, and some skinned up faces in kids that have had some misadventures on the slopes.
Mm-hmm.
So.
And Jonathan Hook, I bet this time of year keeps you busy. What are you typically seeing?
Yeah, inevitably we'll see the people post-op too, after trauma, and then also just the normal strains from shoveling and moving snow around, mostly poorly, but it's challenging to shovel well, and so you'll see a lot of strains of low back, shoulders, things like that.
Mm-hmm. And Dr. Burns, what are you seeing with shoulder injuries this time of year?
I've seen patients who have slipped and fallen on the ice and injured their rotator cuff or dislocated their shoulder. I've seen patients who have been involved in car accidents and end up with whiplash type injuries from not being able to stop in time. So with shoulders, mostly rotator cuffs or dislocation from falling on the ice.
Mm-hmm. And are we seeing back injuries as well?
Sure, see compression fractures. A lot of people fall landing on their rumps, basically. Then most of them don't need anything done, just need physical therapy, sometimes a brace, treat the root cause of the problem, the osteoporosis that weakens their bone that predisposes them to a fracture.
Mm-hmm. So is this also the time of year then that we see replacements, or are patients going to wait until the weather improves, or is that something they jump right in on?
Well, some people have very strong preferences. Some people like to enjoy the summer, and other people are afraid of if they have a joint replacement, they won't be able to walk on the ice. So, it's a variety of things. But people do have more arthritic symptoms. If they have arthritic joints, they usually tend to feel worse in the winter than in the summer. It's basically busy all the time. We have an aging population, and especially at the end of the year, everybody wants something replaced. So.
Dr. Burns, with shoulder injuries, and you do a lot of rotator cuff, you mentioned, what's the latest in rotator cuff replacement surgery and repair?
Well, for rotator cuff surgery, it's typically not a replacement surgery, it's more of a repair, and we want to try and get to the injury as soon as possible. Because
so that is something you would do sooner than later?
Right, because they can go on to become irreparable over time. So if a patient has weakness after an injury, then that is very indicative of a rotator cuff tear, and we'd like to have it evaluated so they have the best chance of getting it repaired.
And how long of a surgery and recovery are we talking about with something like that?
It really depends on the size of the tear. It can take 30 minutes to an hour and a half, and how acute we get to it, or if it's been present for several months. Some people wait and think they just strained a muscle and it doesn't get better, and they come in later. And so if it progresses over time like they often do, a larger tear can take longer to repair. The recovery, I tell patients it can take up to a year after surgery before they really feel normal again, but they're in a sling for about 6 weeks, and then I start physical therapy right away, and I don't let them lift anything for about 3 months.
And that's where you would come in, Jonathan, with the physical therapy.
Right.
How long would they be seeing you?
It's patient dependent, so it depends on how they're doing during their treatment. Like Dr. Burns said, we'll see them pretty acutely in that passive range of motion phase. And then as soon as they're out of the sling, things get a little more interesting. We get to move to active range of motion, and then between 8, sometimes 12 weeks, depending on the size of the tear, we'll start doing strengthening. And then at that time, we're starting to build a program that they can progress on their own to and wean them from our service.
Are there things they can then do at home as well?
Yeah. We try to educate them throughout the experience. A lot of times we're only seeing them like 2 hours during the week. And so a lot of our job is education and motivation. So you're trying to sell basically your treatment to them and show the importance of what they're doing so that they'll use that or utilize that exercise for the remainder of the hours of the week, minus the 2 hours that they're in our office. So yeah, that's huge.
And then making sure they're doing it at home.
Yeah. That's
staying on them about
right.
that.
Yeah.
What's the difference between a sprain and a strain? Because some of these injuries are just aren't quite as acute as others, and we can basically do some home remedies to take care of that.
I think that Jonathan would be the ideal person to ask that question too. Though we see it, we love to send it to Jonathan because he actually can treat it, and we don't so much.
Some of us send ourselves to Jonathan.
Taking some falls on the ski hill, Dr.
No,
Schuster?
I've been a rotator cuff patient, so I mean, can't emphasize enough the importance of icing the cake. Surgery is just a champagne bottle on the bow, but the therapist is the one that finishes the voyage with the patient. So I can't emphasize enough that you got to have buy-in with fixing this. You got to find something that you like to do that gets you to your rehab goals. And therapy may not be therapy, it may be, hidden as fun. You might be doing, TRX like the patient on TV. If you do stuff that's boring and repetitive, people aren't going to do it. You've got to craft a program that they're going to motivate.
We talk a lot on this program about the team approach to medicine. Is that the case with your specialties as well? Is a team approach using physical therapy, surgical procedures as well as other procedures?
I think, particularly with fractures, for example, there's this tension between immobilization for the fracture to heal and stiffness that occurs if you immobilize a joint. So I think it's important to have an approach that includes therapists to help the patient progress through their rehab. There are certain restrictions sometimes with motions that occur with fractures or with rotator cuffs, and so it's really helpful to have coaching with that. So, you know, I really appreciate the therapists.
And there are very few things that we do in isolation that can't be improved on by therapy. I mean, we can put the parts together, but that doesn't mean it's healed. It doesn't mean that they can use it. And the goal behind everything we do is to get someone back to normal function. And just because the parts are together, they have new metal and plastic in their hip or their knee, doesn't mean that they can walk or enjoy the normal things they like to do. So therapy, I mean, it's a team approach throughout, you know, beginning to end, I think.
Okay. When we're talking about some of these injuries, we're certainly not just talking about athletes. Joint and bone problems aren't limited to folks who are particularly active all the time. Aging, even everyday activities can land you in the office of an orthopedic surgeon, as we recently found out when a Spokane man shared his story of injury and recovery.
During the winter months, this is where you'll find Jerry Simpson. The avid skier hits the slopes with his family every chance he gets. But 2 years ago, it looked like his skiing days might be over.
I had my season pass to Schweitzer already purchased, and we were renting a ski condo.
Jerry was coaching his son's soccer team.
I was playing on defense and having a great time with the boys. We were just whooping it up.
And then it happened.
Planted my right foot, twisted, and blew out my knee. It was so loud you could hear my knee pop from across the field.
Jerry had to be carried off of the field and into his car. He knew it was bad, but how bad?
I was hoping that I still had my ACL, and initially it looked like I might have, but they did an MRI. Nope, it was completely gone.
A week later, Jerry was in surgery, followed by rehab.
I started physical therapy really very, very quickly, but then I was wearing a big knee brace, icing it with a chilling machine, and it was several months before I could really put much weight on my knee.
Jerry credits his doctor and physical therapy associates with getting him active again. And that injured knee?
What's funny about it is my right knee, which my surgery on, is actually more stable than my left knee.
2 years after being sidelined, Jerry is back in the gym and back on the ski hill. Any worries he had are long gone.
Okay, this is the end. I'm 50 years old. I've blown out my knee. There goes my active lifestyle.
The injury, he says, taught him 2 lessons.
I think the number one thing is to be as fit as possible.
And second, go easy on soccer.
It's kind of hard to do. We're active people. Jonathan, he was your patient, obviously, and working very hard. How long have you been working with him?
I hadn't worked directly with Jerry for probably about a year, but it was that transition from hands-on therapy to guided exercise to now graduating to our exercise facility upstairs, and then, like what Dr. Schuster said, buying into what's going to work for him to continue to be healthy, as it was the biggest thing for him. So I get to continue to monitor how he's doing just as he goes up and down the stairs to classes, which I think has worked fantastic, because then he can ask me questions about like his return to run program, how it's going right now, and what do you think about me trying skiing right now? And so we've had a continued conversation, but the direct PT has stopped about a year ago.
Okay. It's fairly ironic that he was a skier, but that's not how he was injured. I mean, he just took a misstep on a soccer field, but that's a typical story for baby boomer generation.
Yeah, it happens. It can happen anytime, and it's usually we tell patients that they need to make up a better story. Like my parachute didn't open or something, because to say that you fell off a bar stool and tore your ACL at Sun Valley doesn't really work. So, but that's really what happens. I mean, people. My son, 2 days before Christmas, broke his ankle very badly walking to work when he'd skied for 3 days before that. So life isn't fair sometimes.
Mm-hmm. But with the boomers, what we're finding is this is a more active generation, so they want to stay active, and they're doing more athletic type things, and yet with something as simple as a misstep. So how do we keep from that happening? Can we get a jump on this, so to speak, and do things ahead of time that prevent these sort of injuries? Dr. Linthicum?
You know, I think particularly as patients age, it's important to that they continue to exercise, in particular to maintain their balance. You know, we talk about weight-bearing exercise to increase bone density, and certainly that should be a priority, but I think continuing to make sure you're maintaining balance is important, because whether or not you're able to fix or solve osteoporosis, if you can improve your coordination or keep your coordination, you're going to be better off. So.
And arthritis can also be an issue with the boomer generation as well, and that can complicate matters. Yes?
Very much so. We frequently see people that just will tell you they can't even get off the floor because they're just stiff. And so, you know, my job in my 10-minute clinic appointment with them versus maybe a therapist's 45-minute appointment with them is, you know, we got 10 minutes to pack in sort of lifestyle reorganization, you know. And so I use a lot of sort of things you wouldn't expect. I tell people, you know, okay, what do you like to do? You know, are you an outdoor exerciser, indoor exerciser? Do you got 30 minutes? Can you buy one of these programs? And I give them a list of programs, most of which I've already done, just to run through them and see if they're dangerous or stupid. And I mean, you find that people just live in this little sphere where they only do a certain amount of exercise. And you got to get them outside that to get them prepared for the unpredictable slip and fall, you know, parachute fails to open kind of thing. You know, and so you know, it's got to be, not all of us can do the 45 minutes a day of exercise we're supposed to do, but you know, almost anybody has 30 minutes 4 or 5 times a week to do a variety of exercises, be it solo or classroom based, and just to get ready. And like the balance thing, hip fractures are correlated with poor balance, hip fractures are correlated with early mortality. There's an association between good cognition as an adult and good balance. We don't know the cause and effect, but you know, just moving the whole thing forward, because we live so much longer. We all have our teeth.
we hope.
So, yeah.
What about weight-bearing exercises?
Well, I think to add to what these doctors have talked about for exercises, stretching is really important part of warming up before and after exercises, and listening to your body, trying not to overdo it, maintaining your activity level but starting slow. I think some people want to start an exercise program and they haven't done anything for 5 or 10 years. And what they really need to do is just make sure that they're physically fit enough, maybe see their primary care doctor. Is their heart in good enough shape to really take on an exercise program, especially if it involves cardiovascular exercise like treadmill or biking. But to really stretch, I think, is important to lengthen the muscles and help prevent injury. And to answer your question earlier about sprains and strains, I mean, strain is when you kind of pull a muscle or injure a muscle, and a sprain is when you injure a ligament or stretch a ligament or even tear, partially or fully tear. And that can be prevented with appropriate preventative stretching exercises and then strengthening exercises and cooling down appropriately. And sometimes we can use our physical therapy friends to help coordinate a program for patients that's directed to activities that they like.
How do we know when to use heat or cold on especially those minor type injuries?
I usually tell patients to ice initially to help decrease the inflammation, and a lot of times it's very painful at first after an injury, so the ice will help with the pain and decrease inflammation. When it's a muscle strain, especially around the shoulders and back, and you probably see a lot of this, Dr. Schuster, I often will recommend heating pad for muscle-related pain in the back and shoulder regions, but I don't know what everyone else recommends.
Jonathan?
Yeah, I agree. I say the same thing, kind of that acute injury using ice, particularly if there's a repetitive strain like for shoveling. Some of my older patients that I tell not to shovel, or I say, will you just call me? I'll come shovel for you. Because
they may take you up on
that. What's the copay for that?
What is the proper way to shovel then? Using your legs, obviously?
Yeah,
not quite.
I think I alluded to it before. It's difficult. Shoveling is just difficult because there's just so much load that ends up being away from your spine and your shoulders, and so it's kind of the physics of loading joints. The further it is away, the more strain there'll be. So trying to keep it close to your body is important. But honestly, I tell people buy a snowblower. That's the best way, probably.
Or hire you to.
The neighborhood kit is, I'm sure, available. So
yeah,
I think in limited. Don't do a really heavy load. If you just do a little bit at a time, it's going to take you longer, or you might have to do 30 minutes, take a break, come back and do a little bit more. But keeping it close to your body, I think, is important if you're going to be doing the snow and
Or
keeping on top of it before it gets really accumulated
Yeah.
before you try and go do it all.
Or move somewhere where there's powder.
Move to Arizona.
Yeah.
Arizona.
Arizona, that's right.
Or I'll tell them to be snow pushers too. Instead of doing the lift throw thing, just kind of, pushing it out of the way, and then if you have to, then lifting in the end, but not trying to throw snow violently.
Is one shovel better than another? I've seen different
Yeah,
shapes,
there's some good-
handles,
yeah.
that sort of thing.
There's some good ergonomically designed shovels that are beneficial, but again, I think what we talked about, any shovel, you can injure yourself basically. It's not injury proof.
Okay. We have a phone call coming in from Lynn in Newport. Good evening, Lynn.
Good evening. Thank you. A couple questions. One about what is the difference between a partial knee replacement and a complete knee replacement? And what do you have available for those who are not a knee replacement candidate? Is there any new developments? I heard out of Japan there might be something they were using to replace cartilage. I have bone-on-bone and both knees, and I'm not a replacement candidate, so just kind of want to know what's out there.
Okay. Dr. Keith?
Well, there's a continuum of care for someone who has arthritis. It starts with simple things. In addition to exercise and staying fit and weight loss, which is an enormous issue, medications, if those don't work, we usually try injections, usually a cortisone injection, and there are some other materials that can be injected in the knee that are somewhat controversial. And then the surgery sort of varies. There's people that have mechanical symptoms may benefit from having an arthroscopy where a little telescope's put in their knee and things are cleaned out. But if you're at the stage where you have bone-on-bone arthritis, the most successful treatment for that would be replacement of some kind, depending upon what part of the joint is worn out. If it's just one half of it, then a partial replacement may be appropriate. And that's a hard question to answer for a particular person over the phone, but those are all surgical options. And then cartilage can be replaced, grown, harvested. There are various things you can do with it, but that tends to be for people who don't have arthritis but have a cartilage injury, usually younger, more active patients.
Okay. We have Steve from Moses Lake with a question this evening. Hi, Steve.
Hi.
You have a question for our panel?
I do. About 4 years ago, I fell and tore the right shoulder rotator cuff. After all the x-rays and MRIs and things, they gave me a cortisone shot, and the surgeon basically said it was 50-50 whether surgery would help versus physical therapy, so I opted for physical therapy. And just love you guys mentioning about snow shoveling. About a month ago, I was shoveling snow, and I damaged the rotator cuff again. And I'm wondering whether I should, again, just pursue physical therapy or whether I should really get it checked for possible surgery.
So you have not seen your doctor yet?
I have, and he basically said, see if you can work it out and see if it will improve over time, which it has, but it's still bothering me.
Dr. Burns, his options?
I think that physical therapy is always a good place to start, and I send a lot of patients to physical therapy to begin with, especially if it's what sounds like you have is an acute on chronic tear where you had an old injury and now you had a new injury on top of it. And oftentimes those are not surgically repairable. But again, we can't always know for sure until we're in there during surgery, but we can gather some information about the likelihood of a successful repair. If you have an MRI scan or at least an ultrasound may be informational. Sometimes an x-ray is all we need because people with long-standing rotator cuff tears often have developed rotator cuff tear arthritis, and rotator cuff repair is not a surgical option at that point. You would be more looking towards joint replacement designed specifically for patients with rotator cuff tears and arthritis. But that being said, it can be treated conservatively initially with physical therapy, maybe an injection and medications, and you'll probably get better over time. But I think it certainly wouldn't hurt to come and see an orthopedic surgeon to at least start with some x-rays and maybe have it worked up further with more advanced imaging. But I would definitely recommend trying to keep your shoulder moving with some gentle exercises so that it doesn't get stiff.
Not always easy when you're not feeling up to it, so that's a tough one.
Yeah, and that's why it's sometimes helpful to visit with a therapist that you like that can help motivate you and teach you the right way to do it.
Poke you with a stick. Is what it's not gonna
Sometimes an injection will settle down that acute pain and make the therapy a little bit easier if you're trying to avoid surgery.
Okay. We have Brett calling from Spokane Valley. Good evening, Brett.
Hi.
Hi. Do you have a question?
Yes, I'd like to first of all thank Public Television for this program. I'm really impressed, and I want to thank all the doctors, and I'd appreciate a response from each of them. I'm a physical therapist assistant, and I'm down on the front lines doing all the work with the physical therapists in Spokane Valley here, and 50% of my patients are total joint replacements. And in fact, tomorrow I have 3 total knees within 3 miles of each other, 3 square miles. And I just want to hear their opinion on home health and the joint replacement and pushing the patients. I'm having a ball. I do 7-8 patients a day, and I just want to thank Public Television and the doctors, and thank you very much.
Okay, thanks for your question and your call tonight, Brett. Well, he's a busy guy, and I guess it's you guys that are keeping him in business.
Sounds like it. Yeah, I think home health is, many patients have significant limitations in their mobility immediately after surgery, although the goal is to get them as independent as quickly as they can. So to bridge that gap, I think, physical therapy at home and home health is a great idea for some patients, although we try to keep that relatively short. And for joint replacements, it's oftentimes a week or less that we would like them to get up and go. There's no motivation like going to the grocery store. Got to get out there and do it. So,
Are we seeing more replacements?
Well, I think there's certainly data to indicate that we have an aging population, and the predictions are that it's just going to keep increasing, at least in the foreseeable future. Knee replacement's more common, and then hip replacement. It seems that more people get knee arthritis than hip arthritis, and as John alluded to earlier, patients that carry a lot of weight have a significant increased risk of developing arthritis. So staying active is important.
Okay. I want to bring in an email that we received from Nancy in Post Falls, and she says that I have severe osteoarthritis in both hips with bone spurs. She's 50 years old and able to control pain with ibuprofen and Aleve, but wants to postpone surgery as long as possible. She also wants to know if she should add Osteoflex MSN to her daily routine, or what else she can do to delay surgery. That does bring up an interesting point about some of the supplements that we're seeing on the market and if they help. Dr. Schuster.
Well, the important thing, I don't do joint replacement, but it's a general concept that if someone's got a debilitating problem and they just find that it's getting worse and worse and worse, when do you pull the trigger on surgery? She's never healthier than she's going to be at 50. Does she wait till she's 60 for hip replacement and possibly has what my colleagues here deal with, joint contractures, where she hasn't done much for so long, her joints are so tight, even a new hinge won't move that well. So then again, it's a consultation with an orthopedic surgeon to make sure that there isn't some impending looming problem. As far as the MSM joint replacement, joint data, OsteoBioflex, glucosamine, there isn't a whole lot of hard science behind it, but even I, doing spine, hear that people tell me, I take glucosamine, I feel better, I've run the experiment and stopped it, I feel worse. There is some animal data that says it works. There's some animal data that says it doesn't, but it's a very low risk. And I would defer to the two Jonathans and Dr. Burns about the risks of prolonging waiting for a joint replacement.
Dr. Keith?
Well, I think if you want to avoid having a joint replacement, regardless of what your arthritis status is at the moment, it's stay as active as you can, maintain your balance, your strength, your bone density, and all that other stuff. And don't get stiff, as Erica mentioned before. That's the worst thing, because that's not easy to reverse. Even with surgery, that's a big problem. So if you're 50 and have arthritis in your hips, but you can still get around and still move and do things and enjoy life, there's no urgency. Now, there are some exceptions to that if someone has this impending fracture or something from their arthritis, but generally people tell us when they're ready to have surgery, and that's usually the right time. And if you can get by with Aleve and Advil, then I wouldn't be in any rush at age 50. But John's right. If your life is miserable because of arthritis, you should have it treated somehow. And you really do need to see somebody and see what your options are. And sometimes it is to wait, but other times it's better to get it done before you have a tremendous contracture or something that, we have people that stay in bed for 3 years because they can't walk, and that's a problem. Nothing good happens in bed.
Well, and because of her age, this may be the ideal time. It's sort of one of those, she wants to stave off the surgeries, but it could be better for recovery time?
I get that question a lot. I feel, though, that a lot of patients are staying healthy and fit long past 50. And so I think if they're able to stay in shape for their heart and lungs and stay active and enjoy their life, and take a little anti-inflammatory, there's no rush to get surgery done. However, if they're limping everywhere, if they're having so much pain they can't enjoy their grandkids and doing things that they used to do, they're at risk for damaging their back because they're not walking correctly. So I think there's certainly multiple factors to weigh on, but if she's getting by with Aleve, I would not rush into a joint replacement.
Okay, we have Fran from Calgary. Good evening, Fran.
Hello, thank you very much for taking my call.
And your question?
I think some of my questions have been answered by listening to everybody here. I'll be 70 shortly. I have arthritis in one knee that we've tried various levels of conservative care for, everything from injection, arthroscopy, but I can't do surgery due to the osteoporosis. The surgeon won't do it, and I can't handle the meds. So I wear a removable knee brace, and I use topical diclofenac cream and have some physio, and that's about as far as we can go. And I can't imagine spending the next number of years of my life without doing a knee replacement, but that seems to be the only choice. Any opinions? Vitamin K2, a little calcium. What else?
I think a lot of calcium. And there are other treatments for osteoporosis that you may already be taking them. There's some various medications that can help rebuild your bone density, but the other problem is if you don't use your extremity, you also get osteoporosis or osteopenia from that. So I think you do as much as you can and get as healthy as you can, and I think I would probably move ahead. You may want to get another opinion from someone.
Were you hearing anything in her question that indicated she couldn't have replacement?
Yeah, if osteoporosis and osteopenia are very common in people in your age group. So, we don't like it, but we operate on people with osteoporosis all the time, and they have good, very good results. You just have to be careful when you're doing the surgery.
Mm-hmm. Hearing some conflicting reports recently on calcium, what do you recommend?
I take calcium, calcium citrate, and just your vitamin D levels have to be appropriate, and that's like a real doctor question as opposed to an orthopedic question. So.
Anyone else care to take the calcium question?
Well, I think there's 2 points to that. One is getting the appropriate amount of calcium in your diet. The other is making sure you can absorb it, and vitamin D is important for that. And some patients have some issues with nutrition, and so I think it's important to be evaluated by the GI doctor or nutritionist to make sure you're getting your nutrients that you need and that you're able to absorb them. Okay. So.
Well, also the calcium-containing orange juice is thought to be better absorbed than milk, because calcium is better absorbed in an acidic environment, which some people can't tolerate. But calcium-containing orange juice, the calcium chews, those kind of things. Some people are lactose intolerant or just dairy intolerant, so they just sort of forego proper calcium intake altogether. most people are under-replaced for vitamin D. Vitamin D used to be 400 international units per day. That's because little Tommy's spoon of castor oil in the 30s that he took happened to have 400 units in it. But it's now thought, if you talk to the endocrinologists, that most people need between 2,000 and 5,000 units of vitamin D per day. And it's one of the few vitamins that it's sort of tough to overload on. You know, you can overload vitamin A, you can't really overdose on C, but vitamin D, 2,000 to 5,000 units is probably an average dose for most people, well tolerated, easy to swallow.
Especially this time of year when we're not getting the sunshine that we typically see, and especially in the Northwest. We have Ann in Edmonton with a call tonight. Good evening, Ann.
Good evening. I just had knee replacement on the 11th of January, and I've still got the stitches in. I removed them next Monday. But I was wondering, I noticed that you had somebody saying about vitamins and that. And I was wondering, is there any supplements, like high-dose supplements, to get me up to it? I'm kind of sluggish and at times kind of suicidal.
Well, and I'm not even sure how to address that.
Well, sluggishness could be a seasonal thing.
True.
Seasonal
affective disorder.
Yeah, seasonal affective disorder could be hypothyroidism.
Could be anemia after having surgery. I mean, there are
a million reasons.
If she's on narcotics, those can be depressing. And a lot of patients feel depressed after surgery. There's a lot big, hormone release when you undergo surgery. It's a big trauma, and you sort of have this high right afterwards, and then they can kind of crash. So I don't know that that's totally uncommon.
Something she should definitely talk to her doctor about?
Well, it was only 10 days ago she had surgery, so before your stitches are out, it's still pretty early in the recovery phase, I think. So, yeah, I think maybe that's worthy of mention at her next office appointment, especially the suicide part.
Well, yeah, that's frightening. Yes. When can she expect to be up and moving? Because I think that she sounds like she wants to be up and going, and that might be part of the problem.
Well, I mean, a lot of joint replacement patients, we get out of bed the same day of surgery, but before they're really moving, it depends what you were doing before surgery. And some people at 2 or 3 weeks are getting around quite well, and others spend a year with Jonathan, to kind of get their act together. So it really depends a lot on what you did before the surgery. You don't turn from a big couch potato BMI of 38 person to this super fit uber athlete like that. So
we have, let's see, Jay Loma, is that correct? Jay Loma?
Well, Loma is the town that I'm from. I'm from
Loma. I see, Jay. It showed up funny on my screen. So thank you for calling.
Yeah, I'm calling from Loma, California, believe it or not. And I really appreciate this program. The subject matter here this evening is fascinating, and it's obvious that a lot of people are interested in the calls that you're getting. My question is it's related to orthopedics. In general, we hear a lot about robotics today and how that's impacting medicine. And down here in Southern California, a lot of hospitals are advertising that they have robots to do their surgery. And I'm a little acquainted with orthopedics, and I know it can be a very mechanical orientation to it. And I guess I'm wondering if opportunity comes up here, I need to have a new hip or a new knee or a new shoulder or something, and I'm kind of getting to that age. If I would be wise to look for somebody that's got these Da Vinci things and the robotics and so on and so forth.
The latest and greatest in robotics.
Well, it's depending upon who you talk to, it's controversial, or you can read the scientific peer-reviewed literature. And at this point, and that's today, there is no evidence that robotics specifically for joint replacement in orthopedics confers any real advantages for the patients. The outcomes don't seem to be better. It's not faster, it's not safer, and it's definitely not cheaper. So
other procedures, but not replacement.
Yeah, I mean, I think robots have clearly been shown to be wonderful for prostate surgery and heart surgery and various things, but I think in orthopedics it's not there yet. It may be at some point, but today I don't think there's a substantial advantage of having a robotically assisted surgery.
Okay. We have Anne in Edmonton. Good evening, Anne.
Good evening. I have a question for the doctors. I have a shoulder, I'm in my 80s, a shoulder that is bone on bone. I have had repeated injections, and I'm now on oxycodone at night to try and help relieve the pain for sleeping. And I would really like to know if I can be a candidate for the surgery.
Dr. Burns, would you like to ask Anne any questions?
Well, Anne, I think that it all depends on your overall health in general, but I usually tell patients that don't let age alone be a factor. If that's what you're worried about, being in your 80s to have your joint replaced, we do joint replacements in patients in their 80s. And that being said, I do see some patients in my clinic that say, oh, I'm too old to have surgery, I don't want to go through that and recover from it. What you need to know is that yes, it is harder to recover from a major joint replacement surgery at your age compared to somebody who's maybe in their 50s or 60s, but it can still be done, and it really depends on quality of life. And the one good thing that being your age is that it's unlikely to wear out in your lifetime. We had that question earlier about when is the right time to have your joint replaced, and some people put it off so long that sometimes the joints, especially shoulders, can become not reconstructable if you wear away too much of your bone. So it definitely sounds like this is affecting your quality of life and your ability to sleep comfortably at night. And I wouldn't leave it up to age alone to help you make that decision. I think you really need to look at your overall health and your cardiovascular status and quality of life. So hopefully I answered that for you.
Mm-hmm. And Jonathan Hook, you work with patients of all ages, so it's not unheard of for you to have patients in their 80s?
No, I think that's one of the best parts of our job is to get to treat people on that age continuum. And so, yeah, working with people as they're getting older, for us is what Dr. Schuster talked about earlier, looking at what are your goals right now. I think we deal with function a lot, where quality of life, breaking down our exercises and our programs to what are you trying to achieve right now in life, what are you not able to do, and what would you like to do. And so making exercise specific to that, so doing range of motion and strengthening to try to achieve those goals.
Mm-hmm. And even in her case, just getting a good night's sleep, she was so miserable, she was taking some, narcotics to make sure she could get through the night. So we want to make sure that we take care of those sort of things. We have Howard in Dayton calling. Good evening, Howard.
Good evening. I'm a retired engineer, live in Dayton, Washington. I'm 75 years old, and I ski at Bluewood. I ski and walk and try to stay active. What I'm wondering is your physical skeletal structure. You want to try to keep it aligned and try to keep it as stress-free, especially in bed where you're recommending 8 hours of good sleep. And I just wondered if the doctors have a recommendation for a type of bed that would help support the structure and maybe even be therapeutic to some, where the body can start healing rather than fighting things. And I just wondered if there's something you would recommend in terms of sleeping and which I think is very important to restore the energy back. But I thank you for your recommendations.
Thank you, Howard, for calling tonight. Dr. Schuster.
So you picked on the engineer in the crowd. That's what I was. I just anecdotally, it's kind of nice that the waterbed's gone the way of the dinosaur, because you don't really find too many people that are going back to their waterbeds. So maybe there's a correlation between softer beds are in general worse, firmer beds but not slabs of concrete are better. You need a supportive bed. If you're not getting restful sleep, it may not be an orthopedic problem. I mean, you need to make sure there are not other things interrupting your sleep. Reflux, sleep apnea, other issues, anxiety. But, being a fan of the Tempur-Pedic beds, just generically, they seem to, there is, industry-supported studies that show that people toss and turn less on sort of the Tempur-Pedic mattresses because you don't have pressure points. Whether that's true or not, I don't know. But I don't hear any patients talking about how great their water beds are anymore.
No, those things are awful.
Yeah.
Just awful.
Lava lamps are so cool.
Maybe yours.
So you're a fan of the memory foam style for that
seems
support?
like more supportive because then it'll, but I mean, you need to really look at what is waking you up.
Right.
And if you need and fortunately there are, sleep studies being done now where that is studied. Is it something as basic as your oxygen level drops and you are subconsciously being aroused and not knowing it? And if you're not dreaming, that's important because dreaming is very important to get restful sleep. Dreaming is how you make memory. Dreaming is much more important than we ever knew. And so, I mean, you need to sort of have classic 6 to 8 hours of sleep with dreaming. And if it's not going well, get it looked at. There are people who specialize in this.
Okay. We have Mary in Spokane. Hi, Mary.
Hi. Can you hear me?
Yes. Do you have a question?
Yes, I have a couple of questions for the panel. I'm looking at an upcoming total knee replacement. The bottom part of my leg is kind of going, my left leg is going outward, and I'm real knock-kneed because of the osteoarthritis that's developed. Someone had told me, well, those surgeries aren't successful if your leg is in that proportion. I'm wondering, if that is true. They said it's hard to get a good alignment. The other question I have is, years ago when I had ligament reconstruction, they used a passive range of motion machine that you would lay on. You would lay on the couch and put your knee in that, and it would move it. I've heard that is no longer being used and wondered why that isn't. And then as far as the calcium issue, I have bone spurs. I developed bone spurs, and I have osteoarthritis in my back, degenerative disc disease, and my facets are degenerating. My rheumatologist told me to take vitamin D, but not calcium, because that may promote more bone spurs. So I'd like to just get some feedback from the panel if I could.
Okay, let's see. Let's start with the back issues, Dr. Schuster.
It's a tall order. With back issues with regards to the bone spurs or
the disc?
Yeah, the discs. I'm not aware of any science. John might know because he's the scientist in our group. I'm not aware of any studies that show that increased calcium intake causes more bone spurs. But there are some people that make spurs. There's some syndromes, DISH, DISH, other things like this that create spurs. And so I don't know that there's a specific answer with regard to the back question, other than, if there are people that are predisposed, she needs to make sure she doesn't have an autoimmune disease that promotes these kind of things, that might explain what she's describing, a valgus knee, John? So
that's what it sounds like.
And that's where her leg isn't aligned with the knee?
So one of the most important things we do when we do joint replacement surgery is correct someone's malalignment, and you try to make the joint surfaces parallel to the ground. And so people are either, some people are straight, but most people are either knock-kneed, and we have fancy Latin names for that, but it's knock-kneed or bow-legged. It sounds like she's knock-kneed. And that's something that's correctable at the time of surgery. It's harder to correct, as I'm sure you think so too. But it's important to correct that for the sort of optimal result, but it's correctable certainly.
Mm-hmm.
Yeah. The valgus knee is certainly one that has some complications associated with it. And so, I think it's good to warn patients that they need to be aware of that before they're going into their surgery. However, there's plenty of patients that come in that are knock-kneed, and we're able to correct them and get them back out and functioning. So
And then she mentioned a particular piece of equipment that she had worked on. Was that something you're familiar with?
The CPM, I think, did you mention? Yeah. I'd be interested to hear what some of the other docs are saying about CPM. We see it less now. I think it had a phase where it was popular, and then now it's not as popular. And certain docs, I think, order it still for certain things. I think with some of the ACI procedures or some of the cartilage transplants, they're liking it now.
So it was CPM, continuous passive motion, as a machine that you put your leg on and basically it moves back and forth. So it doesn't require any energy on your part at all. And we used it religiously on everybody, but what we found is that people who didn't use it actually did better because we make them get out of bed and they make them move their leg actively. So it's very rare that we use it now. There are certain specific things that Jonathan was talking about where we might use it for cartilage restoration, that kind of thing. But for most patients with joint replacements, we don't use them anymore. And some people who used to have them miss them, but actually they do much better without. Has that been your experience?
Yeah, I actually haven't really used them since I've been in practice. And there were some studies that came out where they randomized patients to using the CPM and not using the CPM, and there was really no major differences. So they've gone away for the most part.
It's also expensive, and a lot of people got back injuries from lifting this heavy machine in and out of the bed. Usually their spouses got so.
Okay. I want to read an email that we received from Dan, and he says, I tore my rotator cuff about 30 years ago. After about 2 years, it got better. Now it hurts all of the time. I suspect it's arthritis. Is there anything that can be done now without surgery? Dr. Burns.
Well, I think of trying to avoid surgery options include medical management with over-the-counter or prescription strength medications. Injections can be offered. Usually we're talking about a cortisone injection into either the subacromial space or into the glenohumeral joint, the shoulder joint itself. I do suspect that it is arthritis, and so there are a couple of different surgeries that can be done. But if you're really trying to avoid surgery, I would say anti-inflammatory arthritis type medications. I do send patients to physical therapy to try and regain some function. That's range of motion and strengthening, and possibly considering an injection.
What kind of exercises would you suggest for Dan?
Yeah, I think initially as a PT, since we're kind of movement specialists, you're looking at movement, the quality of movement overall. And so you're looking at how the scapula is moving in relationship with the humerus. So sometimes with torn rotator cuffs, you're going to get a faulty movement where the rotator cuff, the job of the rotator cuff is to keep it nice and snug in the glenoid cavity. And if it's not functioning correctly, then you're going to have this elevation of the humerus, which sometimes creates a lot of pain from impingement and things on other structures. So sometimes it will get better in this case, and then it'll come back because of that faulty movement that's created this impingement or irritation of structures surrounding that joint. So a lot of times we'll kind of dissect maybe that faulty movement pattern, and even if there's a tear in the cuff, we can still strengthen the scapular stabilizers to help promote better movement overall from that glenohumeral joint and some of the scapular stabilizers and things that move the shoulder as a whole.
So it sounds like this is probably something they want to see a professional for and not try to do on their own.
I would recommend that.
I would recommend he at least get x-rays so he knows the diagnosis. Is this arthritis? Because if it's bone on bone, sometimes even exercises aren't going to alleviate that pain that is caused by the arthritis.
We are getting actually close to the end of the show. We've had some great questions from people coming in tonight, but I want to get some final thoughts from each of you about the topics of joints and bones, and maybe what you're seeing for future treatments, or how we're progressing as far as an aging generation goes. Let's start with you, Dr. Keefe.
Well, the most rapid growth in people who are developing arthritis is in people between 45 and 60. And it's projected that the demand for joint replacement is going to increase about 300% in the next 20 years. So that's going to be a problem, just because there are only so many surgeons, I guess, to go around. So anything people can do to prevent this development of arthritis is helpful. And probably the biggest thing is to stay in shape and don't weigh 450 pounds, because probably the biggest cause of arthritis we see now is obesity, which is it's a pandemic. I mean, we see heavier and heavier patients, and all we do is keep raising the bar. So staying light and staying strong and having good balance I think are the big things. If you want to avoid seeing us, that's what I would do.
Okay, Dr. Burns, some final thoughts?
I think there's a lot of options for treating it initially non-operatively, and if the symptoms persist, I mean, surgery is always an option, but really it depends on how severe the pain is and how it's affecting someone's lifestyle. And there are different surgical options too. There are clean out type of surgeries before joint replacement surgeries, and there are different types of joint replacement surgeries depending on the specific type of arthritis. And so I think that if there's any question about are you a candidate for surgery, or are you interested in it, what can we do to try and preserve the joint, I mean, visit with an orthopedic surgeon.
Okay, Dr. Schuster?
This is a little off base, but it leads to, we've heard about osteoporosis a few times today, and the sad fact is if you have osteoporosis, you're only 20% likely to get treated by your primary care doctor for it, which is incredible. If you see an orthopedic surgeon, it's 56%. So just by getting plugged into the system and not sitting home with a rotator cuff for 30 years, and potentially having the downfall of that, and what's called a frozen shoulder, where it's so stiff that a terrific surgery by Dr. Burns can't even get the thing moving again. It's not just about bones and joints, it's everything underneath. It's cardiovascular health, it's balance, it's bone density, it's cognition, it's recognizing and treating dementia. I mean, that's why I went in orthopedics, because it's such an incredible biopsychosocial experiment. We talk about all kinds of stuff in clinic. Clinic is a blast because we have so much fun talking about all the things, and we talk about weight loss and exercise. So it's the whole person. But don't forget osteoporosis, the fifth vital sign.
All right, and quickly, Dr. Linthicum.
I think if you do end up needing to have joint replacement, it's nice to know that, in the timeline of the earth, you've picked a good time to have joint replacement, because we have options. Even 50 years ago we didn't, and we have great aids with pain management around the time of surgery. So I think that should at least decrease the fear when contemplating surgery. Yeah.
And for Jonathan, I'm going to say just buy a good snow shovel. I appreciate you all being here tonight. Thanks so much to our panel, and that will do it for this edition of Health Matters. I also want to thank everyone who called and emailed with their questions this evening. Now join us on February 25th when our topic will be heart health. I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSBS, and by Providence Healthcare.
As the saying goes, children aren't just short adults. They have special needs. I'm Dr. Judy Felgenhauer. I chose Providence because they see the need for specialized care just for children.
Find your doctor online at phc.org.
Providence has the best professional and the best nursing staff, without which we could not do these complex procedures. I'm Dr. Stephen Nisko, and I choose Providence because Providence is fully invested in my success and in the success of my patients.